Just in case we have questions. Hi, everyone, and welcome to our What's Up Doc series. I am so excited to have with us today an amazing podiatrist slash inventor and entrepreneur. We have Dr. Chris Bromley. He works out of Florida, and he's here to answer our burning questions about our feet and how issues with our feet might be related to vascular issues or some other structural issue, but we're going to be talking about all of the above. Get your questions ready for Dr. Bromley. But as you're coming up with the questions that you might have for him, we're here at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. It's where they have different tracks where doctors learn from other doctors, new advances and tools and techniques. When it comes to issues related to vascular diseases, particularly peripheral vascular disease. And peripheral vascular disease is a disease of both the arteries and the veins. If it's just arteries, then it's peripheral artery disease. If it's just veins, it's chronic venous insufficiency. And there are probably a lot of other related conditions that go along with that. But in the meantime, not only is he a practicing podiatrist, but you're also an entrepreneur and you're working with a company called CarePix. Can you talk about your foray into the entrepreneurial world and what you're trying to do with the organization CarePix?
Again, thank you for inviting me. It's a pleasure to be back. Pleasure to see you. And CarePix is really a passion of mine. One of the struggles that physicians face is the ability to accurately assess patients who present with wounds, and how do we measure them? How do we document them? How do we coordinate care with other providers? And how we communicate with our patients. So CarePix is a tool that I use, and many of the doctors we work with use to image, measure, document, and then treat. So the treatment may be referring to a vascular colleague so that we can share that information. And then most importantly, we communicate with our patients. So if you have a wound, you have a 24-hour, 7-day-a-week access to your team of physicians, which really is something that most patients really appreciate, because you can communicate with me at any hour. You're changing your bandage, you see your wound, or something's changed. Well, ordinarily you'd have to maybe come to my office or find my number or get my office to get me to call you. Really, the wonderful thing about CarePix is you can tap, you can send me images, you can communicate with me. And no matter where I am, I'm here in New Orleans today, but if I have a patient home, they can communicate with me and I can respond immediately. So it's really the evolution of that 24-hour concierge medicine.
Wow, that's amazing. I mean, when do you sleep? Do you ever sleep?
I do. I love sleeping. I typically sleep about 8 hours a night. But when I'm up, I'm like that sort of Tigger. I'm always going. I've always got something on my mind. I'm always looking to develop and do something interesting.
So CarePix, it's an app that both physicians, their entire care team, as well as a patient can actually download this app and they can communicate. They can quickly and easily take a picture of their wound and get that assessed by that team in real time.
Absolutely. It's really the evolution of technology. We all have smartphones.
Right.
We're all communicating with each other. We're used to getting our news, our information, communicating with our friends, social media. CarePix is really the evolution of using that tool, because the information that I have in my medical record about a patient is really sequestered in my medical record.
Right.
It's not available for the other doctor across town or another doctor who may be at the hospital. So CarePix is really a way to link all of those things that the patient and the provider needs to have the outcomes that we really want to have.
That's fantastic. And do you have your entire team on there? And then, the patient's in there, and then all of you get notified when there's something that comes up. So, whomever might be available in that moment can address it in that moment.
Yes, it's really amazing for me. In our group, we can use the technology. It doesn't, as a provider, you don't need to be the person always there. You can designate your staff to have somebody who's going to be triaging those messages. You can also use it to push information to the patient that they might need, like some education, how to take care of your problem, how to change your bandage. You have an appointment coming up next week. Maybe you can't get in because you have a transportation issue or you might be homesick. You can use CarePix to telehealth with your provider, and it's really easy to use. Uh, Oftentimes patients, well, how do the patients do it? It's really super simple. It's like FaceTiming your grandkids,
Right.
or taking a selfie and sending me a picture. That's how easy it is. And it's no cost to the patients. And it's extremely reasonable, very, very inexpensive for providers.
One of the educational pain points for patients, and we deal with this every day, is that wounds are a 24/7 issue, right? And you can't see your physician or your care team every single day. And it really becomes where literally every couple of days, I mean, you have to change your wound. You have a nurse practitioner that comes to your office or whatever it might be. And not to your office, but to your home. But in between, you don't know what's going on. And it's scary. And wounds can change overnight. And so if there's not one resource online where patients can actually go and get trusted information on the evolution of a wound and what to look out for and see pictures and be able to compare their pictures, like with an AI. I mean, the advancements in AI, that could be amazing, where they could upload their picture and another picture from the system can come up and go, you might be in this stage, contact your doctor immediately.
That's
So that's not available.
Yeah, you're so right. And I think that we're getting there. And I think one of the things that I notice about CarePix is when I see patients in clinic, there's a image and measurements, and then there's a trend line for how the wound is doing. The patients like to see that trend line. And oftentimes
Yeah.
if I took a picture and I'm busy doing what I'm doing and I don't show the patient the trend line, they're like, wait, show me the trend line, because they want to see, they like that positive reinforcement that they're getting better. So that's really something that's been helpful. And I think you can send information. And what I often do for patients is I say, listen, show your husband or your wife the picture of your wound. Because a lot of times, if the wound is really a difficult wound, the only time it's unwrapped is when it's in my clinic.
Yeah.
And it really takes a village to get everybody better. Encourage somebody to go for, their visit, or encourage them to take their medication. Being able to share with your family and your loved ones what's really going on with your wound really is helpful for getting everybody to be on the same page and getting us healed.
How helpful has CarePix been with, let's say, newer technology in revascularization, which is called the DVA, the deep vein arterialization? Now, this is a very specialized Hail Mary procedure for patients that literally are on deck for amputation. And there's this one last chance where the doctor can actually hijack a vein and reroute blood flow through a vein into the foot with the sole purpose, and this is the only time this DVA is really used because it's such a Hail Mary, is when you have a wound that will not heal and amputation's the next step if you can't figure out a way to get blood flow to help heal the wound. The issue that we've seen with this technology, I know you know where I'm going with this, is that the wound gets worse before it gets better. The pain gets worse before it gets better. And I would imagine having a system like yours that where the patient can be monitored and get the real-time feedback and support would be imperative. I mean, it would be game changing, because I've had patients that have had a DVA and have called me and said, oh my God, I just want them to cut it off. And I'm like, take a deep breath. Are you sure about that? Because one more week, I think you're at that purge. It's gonna be an inflection point for you.
You're 100% right. And we were involved at CarePix in part of that FDA approval. They used CarePix as the tool to track those wounds
I was wondering
to get their indications. So we were the tool that they used, and we're very grateful for that opportunity. I think from a physician's perspective, communicating with patients is something we could always do better.
Right.
And CarePix really is a tool that the patients can receive information, what their expectations are going to be, what the wound looks like. They can communicate with their providers. They can send the office and ask questions about that. And I think it's really important for us to explain to patients what they should expect. This is what's going to happen in the first week. This is what's going to happen in the second or the third week, and always reassuring them that this was the right choice and a much better choice than amputation, because we know if you do have any amputation, you're statistically going to lose the other leg within less than 5 years, and you won't be around in a very short period of time. So we're looking to do whatever we can do to make sure that we keep the legs attached to our patients.
So, for those patients that do end up with a DVA, talk about the process for that wound healing and what patients can expect, and maybe kind of that timeline to hopefully seeing, a light at the end of the tunnel.
Yeah, full disclosure, clearly my specialty is obviously treating the wound, and I rely on my vascular partners to do the revascularization. But
Right, but with the wound in particular, you've seen what they look like in the
yeah,
process, that
yeah.
that the wound healing.
Yeah, there's a dramatic change because what's happened is you're reversing the entire blood flow. If you think about a wound, and the wound has, prior to this event, it has blood flow in and then blood flow out, and then you're hijacking the vein system to be your new inflow. So you're going to expect that the bed, the tissue underneath the wound, which is a complex of arterial and venules you're going to expect that flow, that system, to be in shock.
Mhm.
So the wound is going to look really ugly, you know, for a few weeks until you get enough revasculars, enough flow,
Mhm.
and enough protein and enough oxygen to basically change that. But you're gonna expect it to be worse. And I think that, it's really important to manage the patient's expectations, make sure that the wound is receiving the appropriate care. There's so many things that you can do to supplement that. And in my office, we have lots of very cool tools. I'm a tech guy, obviously.
Mhm.
I had a patient the other day who had a wound on her leg. She had polyvascular disease, arterial venous, and it just wasn't coming along. Even though I was doing the best that I could, I said, let's try some laser. So we did some class 2, and then we did a class 4 laser. That's a way of using a technology to stimulate those cells.
Mhm.
So in my particular practice, where in previous time I would just have to wait and see. Now we get proactive. We just say, listen, let's come in 3 times this week. Let's laser that wound. It doesn't hurt. It's not painful. And we're able to stimulate that wound bed. So you can have the wait and see, but you can also deploy other technologies to improve the way that the tissue, when you're using laser, it's what we call photobiostimulation. So you're using the energy from the laser to stimulate the wound at a cellular basis. There are also modalities that we use, like cellular tissue products. We use amnion, chorion allografts. We use exosomes. We use different cells to stimulate the wounds to heal where the body doesn't have the ability to do that. We have the ability to use those technologies. So we have lots of tricks up our sleeve, and we try to be as proactive as we can.
But not all podiatrists have this technology. Not all podiatrists are on the cutting edge. And so, give us the critical questions that patients, especially with peripheral vascular disease, should ask when interviewing a podiatrist to determine if they're the best podiatrist, most advanced podiatrist for their situation, because these patients have a great chance that they're going to, if they haven't already, develop a wound and are going to need someone who's on the cutting edge.
Yeah, you're 100% right. In fact, I gave a talk this morning in the primary care about
Okay, very timely.
yes, I gave a talk this morning to the primary care doctors about what type of a podiatrist should you be working with. And they're like, just like any other specialties, you've got a vast spectrum of abilities, whether you're a podiatrist or a primary care or a interventional vascular specialist. I think that I would ask, what is my current situation? What are my treatment choices? What is your experience? What should I expect? And is there anything else I should be doing? And if you're not comfortable with the podiatrist that you're seeing, it's always a good idea to get a second or third opinion.
Mhm.
I tell my patients all the time, if I'm going to be doing something that's very complex or high risk, or they're in a situation, I'm like, please go out and get another opinion. I want you to talk to other people because I want you to feel 100% comfortable that what we decide, the patient and I as partners decide that we're going to do, it's the best thing. But I think to answer your question, you should be going to the best trained podiatrist you can get to.
Are there any indications, though? I mean,
Yeah.
sometimes I'll tell, at least with vascular, I always say to the patients, okay, you need to ask your doctor which conferences they go to. Do they go to a conference like this one, the New Cardiovascular Horizons? Do they go to AMP? Do they go to VEITH in New York? Like, do you go to these conferences? How often do you go? Are you on the podium? What do you typically talk about? I know that sounds a little bit more advanced and it's not the typical thing you would hear, but I would imagine, I see you smirking. You agree, don't you?
Yeah,
Especially even for podiatry.
yeah, no, I think that's great advice. I never thought about giving that advice, but I think I do it intrinsically. It's like you wouldn't go to a restaurant without looking at the reviews,
Right.
right? So the same thing is true with physicians. I think looking at reviews of physicians is important to do. I think Googling a doctor and seeing what they're up to. If you go to a doctor and you walk into their office and their waiting room is sort of disheveled and not up to date and not modern and not neat and organized, that's a bad sign. And if you Google them and they've got bad reviews or they're not, their website is very old and not progressive, they're probably not progressive. They're probably not going to conferences. So I think, the first thing to do is make sure that you're going someplace that's modern, that's up to date. You judge the waiting room, you judge the reviews, you talk to the doctor, and make sure that that doctor is board certified and is doing a member of the local hospital, doing procedures, and that based on their social media, based on what they're putting out there, that they're doing cutting edge work.
And podiatrists are not all specializing in peripheral vascular disease, although likely everyone you go to will say, I guess I'm a podiatrist, I'll do everything, but they might specialize in, let's say, sports medicine versus peripheral vascular disease. You definitely want someone who, especially for diabetics, that specialize in diabetic foot. And a lot of times on their website, they will in fact say that they do specialize in diabetic foot and vascular issues.
Yeah, I think that's a great point. One of the things that I talk about, and one of the talks I gave this morning was about the importance of doing PAD testing. In fact, 50% of patients with PAD have no symptoms at all. And the same thing is true with patients with deep vein thrombosis and other types of conditions. So I talk to podiatrists all the time about you should be doing testing in your office. You should have, if you don't know how to do it, you can hire somebody to come in and do it for you. And if you can't do that, you should be linked at the hip with your vascular colleague. So around the corner from my practice, I have Palm Vascular. They're a great practice. I communicate with them on the app all the time. We triage patients back and forth. But I think choosing a podiatrist and seeing, what they're doing. If you have PAD and your podiatrist has never done any testing for you in their office or anyplace else, probably should see somebody else because they're not passionate enough or don't or not focused enough to really help you with what you need to have.
Right. And especially if they're going to be doing debridements and stuff, you'd think they'd want to use a device like Biomedics has that is an in-office testing device for your blood flow.
Yeah.
Right then and there, before they start poking away, they got to make sure that you have enough blood flow to heal whatever they're going to be doing.
Yeah, that's another great point, and I love what they do at Biomedics, and I work with them for years. I tell physicians all the time, the standard of care for a wound patient getting arterial testing is the first visit.
Mhm.
You need to schedule it. If you should not be waiting a month or 2 months. And all too often, we know I do quite a bit of work in malpractice, and we know that 70% of patients who are involved in a leg off malpractice case have had no PAD testing at all. And that's absolutely unacceptable. And the 30% of patients who did had an ABI, which is not, it's a good first test, but it's not enough to determine whether or not the patient's going to heal. You need further testing with TCOMs and digital blood flow, looking at near infrared images, which we do in our office. That's so important to make sure that you're doing the appropriate kind of testing and you're doing it at the right time.
I'm going to let you put this in. I think we have some questions that might be coming up. If you have a question for Dr. Bromley, go ahead and unmute. It looks like Kim might have a question for Dr. Bromley. Kim, do you want to go ahead and unmute and ask your question?
And hi there.
Hi, Kim.
Hi there. I was just wondering, if you have an ingrown toenail, is that something that should be dealt with, or if you're not really if it's not too serious, you can just let it go?
As a peripheral artery disease patient, especially.
Yeah, so that's a
Right.
great question. I absolutely believe that your ingrown toenail needs to be treated. If you are calling me today, I would give you an appointment today or tomorrow, because it may be something simple that we can kind of help you with easily, but it may require some more treatment. But especially if you have PAD, an ingrown toenail may be an ingrown toenail, but it may be something more significant. So I would definitely get it looked at.
A question. Thank you, Kim. a question from Tiger. Tiger, do you want to go ahead and unmute and ask Dr. Bromley your question?
Hi, Dr. Bromley.
Hi.
I have PED, but I also have peripheral neuropathy. And the PN impacts two things, walking, and it causes intermittent pain in my feet and toes. Can the PN lead or contribute to foot wounds? I currently don't have any foot wounds, but I'm concerned about down the line.
Yeah, that's a great question. So yes, they're connected. The reason you have PN is that because of the arterial disease, the very smallest blood vessels you have, are called the vasa nervosum. Those are the vessels that go to the nerve. Those are the ones you lose first, and that's why the PN occurred, the neuropathy. So yes, you want to know that your PN and your PAD in combination can put you at risk for a wound. So daily foot exams, making sure you're seeing your doctor, the appropriate shoe gear, the appropriate socks, not going barefoot, proper nutrition, exercising to the best of your ability, super important things to do. And in our office, we do lots of low-level laser for the PN patients because I can influence the blood flow. In fact, across from us is a wonderful company called Ken Imaging.
Yeah.
They do near infrared imaging of the foot, which looks at the amount of oxygen that's being delivered to the skin. I can improve your blood flow at the skin level, the smallest vessels you have, by 20% with just a 12-minute treatment with low-level laser. So with my patients who have PN, we use a combination of diet, lifestyle, nutrition, supplements, and low-level laser to try to reverse that. In fact, if you go back and statistically look at the Jacobs and Chang study, they showed a 90% regrowth of C fibers in 6 months by using medical food and B6, B9, and B12. And then we've made that less than 6 months using the low-level laser at the same time. So PN is not something you need to live with. It's something that you need aggressive treatment for.
And if they were wondering, like, for example, with Tiger, could she call, let's say, a Kent's Medical Imaging or the laser company? I'm not sure the name of the laser or how many laser companies there are that do this particular type of lasing, but could she say, hey, what accounts are open in my area?
Absolutely. There's a couple of companies I work with on the laser side. There's Erconia, which is ERCHONNIA, and then another company called Berman Laser. They actually can direct you to physicians in your particular area. And the same thing with Ken Imaging. They have that in a lot of practices. And those resources, they're happy to refer you to people that and get you to the right place.
Tiger, did you want to add to that?
Yes, thank you. Because my podiatrist is useless. So I'm looking for somebody who could kind of look into it with a little more depth.
Well, I feel your frustration, and I think that's the wonderful thing about this forum and what Kim is doing, is bringing this information to you so that technology like this can help raise the level of care by making sure that you're able to receive the best care. In fact, when I'm lecturing from the podium all too often, I tell providers, listen, you're the third doctor that your patients have seen because they went to Dr. Google and Dr. WebMD before they came to see you. So you better advance your care because if you're not doing progressive medicine, your patient's going to go someplace else. So I would encourage you to get the best care you can.
And Tiger, you saying that you feel like you don't have any faith in your podiatrist right now. How much hope does it give you to hear Dr. Bromley speaking about what he's doing and these other doctors actually learning new advances? And does that inspire you to now go, okay, there has to be someone out there. I am going to get off this call and I'm going to try and find one that has the more advanced philosophies?
See, I didn't even realize that there were other things that I could follow up with. So I'm so grateful for this and to you, Doctor.
That's awesome. Well, I wish you the best of luck.
Thank you.
Thank you, Tiger. And you
yeah.
can always drop back in with another question if you have it. But I want to
Okay,
move on.
thank
We
you.
got an email question from she's just going by the letter J. She is getting ready to go for a revascularization. The last one failed. She sent in a picture of her foot. She's an African American female. She's having a revasc next week, has a wound that won't heal, and has developed blisters just in the past 24 hours and is concerned about the blisters that have developed and if she needs to get into an urgent care or if she can wait till next Tuesday, possibly when she goes in for her revasc.
Yeah, obviously I really I'm concerned because the blisters are usually not a good sign. Your skin is the largest organ of your body. And when it starts to do that, it needs to be treated because that with the underlying PAD, your body doesn't have the immune system to fight off an infection. So I would not wait. I would get in to see somebody and make sure that those blisters are drained, that the appropriate cultures are taken so that you can make sure you're on the right antibiotic. Because if you let that go, you might not be able to have the revascularization because you had a local infection. So I wouldn't wait. I would go in and get that treated. And make sure that you're on the appropriate wound therapy as well as on the appropriate oral antibiotics. Now, the trouble with patients with PAD is that it's very difficult for the antibiotics to get there.
Yeah.
So because you don't have the plumbing, therefore the antibiotic needs the plumbing to get there. So being able to have the local wound care, that means that those blisters need to be drained, they need to be cleaned, and they need to be dressed with a topical antibiotic as well.
Talk in detail on the on when a patient has a toe wound and it's infected, how the medications, both orally and intravenously, struggle to reach that wound without having a proper revascularization ahead of time.
Yeah, that's a great point. Oftentimes we think that if we take an antibiotic that we're okay. In patients with PAD, especially in patients with PAD and small vessel disease, which we call SAD. So there's no way for the antibiotic that you took in your mouth to get absorbed by your stomach and then to get circulated to the wound because there's no blood flow there. So in patients who have advanced disease, the way that we give them antibiotics matters. So it may be a case where I will admit the patient and put them on an IV antibiotic initially to get as much of a response as I can and then convert them over to an oral. Also, if you have patients on oral antibiotics and it's not responding, you need to make sure that you've taken a culture or done a PCR test. PCR stands for polymer chain reaction, where we look genetically at the bacteria that's present and is there a genetic link between the appropriate medicine. So not every antibiotic is going to work for every infection. Not every antibiotic is going to get there. And you need to make sure that you're using the right drug for the right bug, which is what we call the bacteria. And we want to make sure that the patient has enough blood flow to actually get that. And sometimes I'll use a combination therapy. Well, I'll be using an oral antibiotic. I'll be doing a topical. I may be doing some cold laser. A lot of the dressings that I use in patients who have complex wounds, there's antibiotic in the dressing. So, for example, we use a lot of silver. So I'll use a silver alginate dressing. That is a dressing that has silver. Bacteria doesn't like silver, it kills it. And the other key is in the hands of your wound care provider, debridement really matters. Now, debridement can come in different ways. Debridement could be classic debridement where we're taking a scalpel and we're actually debriding away the dead tissue. But debridement may be simple as something where we use microjet technology where it looks like a water pick. We're using a water pick. You don't do this at home with your water pick, but in the doctor's office, the way that we flush and irrigate the wound aggressively with water takes something away called bioburden. And bioburden is a layer of bacteria that lives. You can't see it with your eyes, that lives there, and it can colonize and make your wound worse. And it can also suck any nutrients that we need to heal away. So the care of the wound and the dressing is super important.
I'm going to talk about something that has been talked about very much, which is lint and the impact of lint on these wounds, because we can't seem to get rid of lint. And every one of these dressings has lint on it. There is a company that's emerging that is working on these dressings that there is no lint. But I mean, there's nothing we can really do about it now as much because lint is lint, but I'm curious about because everyone has lint at home and just
Dog hair.
dog hair, whatever it might, cat hair, cat kisses. Yeah, no. We've seen it all actually, but it's just, I want to drive home the point that really how you care for your wound at home and really making sure it's as sterile of an area as possible, and your hands and your clothing, whatever, as sterile as possible. But I want you to explain why. And I know you know who I'm talking about. Norm Furbush, he's an entrepreneur and an inventor that is always at these conferences and is developing these lint-free dressings. Would you mind talking about what you know about it and what you're excited about with that new technology?
Yeah, hats off to Norman and obviously the work that he's doing. I think that we think about the wounds and we think about what do we don't want in the wounds, right? What we don't want to have anything in the wound that's going to cause it to get more infected. We don't want anything in the wound that might be an inflammation or something that might cause the wound to react in a way that we don't want it to. So the first thing is obviously the wounds and everything that goes on the wound and everything around the wound needs to be really clean. So basics, like if you get in your shower and your shower has bacteria in it and you get in the shower and you have a wound, the bacteria from your shower is getting in your wound, the wound bacteria is getting in your shower, maybe spreading it to the rest of your family. Washing, good wound hygiene, washing your hands, using gloves, making sure that your wound is covered at home and that you're safe. Super important. As far as what we put on the wounds, finding wounds that are going to go on, finding dressings that are going to go on a wound that are going to be low inflammatory and promote healing and not aggravating a wound, I think is really brilliant. And I know from as somebody who's allergic to talc, I became a physician back around 1990, and yeah, and I struggle as a physician because I'm allergic to gloves with talc. Because I've washed my hands a few million times over 33 years. And I know that talc is really irritating to my skin. And I know from a wound care perspective, I don't want anything on or near my wound that's going to make that wound unhappy. And the type of dressing that you choose is super important.
What are your suggestions for dressings?
And
You were mentioning the silver.
yeah, so dressing for me, it's pretty simple. Dressing determination is based on drainage. So if I have a wound that's dry, I need that wound to be a little moist, not wet, but a little moist in order for the epithelial cells and the granulation to advance. So I'll choose a dressing that may be a dressing that is a little more of a gel dressing. If the wound on the other end of the spectrum is draining, let's say it's a wound related to venous insufficiency, those are high draining wounds. So I will typically use a foam, maybe a foam with silver, so that I'm going to absorb all that drainage, because too wet is not good. You need to have a wound that's just right, a little bit of moist, not too wet. So I'll choose dressings based on how much drainage. And then the second determination for me is location. So where is the dressing going? Is it going to stay there? Because obviously if I put it on the toe and the patient comes in a week and it's up by their ankle, not so good. So being able to get the dressing to the location and then be able to make sure that it stays there. And a big part of wounds in the foot is offloading. How do I offload? How do I keep you, the patient, from walking on something I'm trying to heal? So offloading with a secondary dressing or a cam boot, super important.
Fantastic. I want to get to some of your questions. I see a whole bunch of them rolling in here. I first want to make sure that if you do want to ask Dr. Bromley yourself, you have the opportunity to do so. So Tammy, why don't you go ahead and unmute? And I know you have a long question there. Do you want to go ahead and unmute and ask your question personally for Dr. Bromley? I don't hear Tammy, so let me read. She actually just wanted to send a comment that she's actually really enjoying the conversation and learning so much about foot care and what she can do. So thank you so much, Tammy, for that comment. Who else has a question coming in? Okay. Joan, are you on here? Do you want to ask your question? If not, I can see it right here. How many peripheral neuropathy patients also have peripheral artery disease, or can you have peripheral neuropathy without having peripheral artery disease?
That's a great question. My philosophy on PN is that PN, particularly, let's talk, for example, about patients who are diabetic. When you have diabetes, you have elevated blood sugar, and that causes a decrease in nitric oxide, and that causes the small vessels to die. So a lot of patients have a form of neuropathy that starts well before they're diagnosed with diabetes. So typically what happens is your autonomic nervous system innervations go first, and then you lose your C fibers next. So I would tell you that the small vessels are affected before the big vessels in most patients with PAD. There are some rare exceptions, but the answer to the question would be your PN is usually a result of the decreased flow on the small vessel side. There are some exceptions to that. Patients can get PN if they've been on chemotherapy. Obviously, COVID caused a change in that. There are some other drugs that can cause that. So, and then oftentimes when we're assessing a patient for neuropathy, we make a differentiation between large fiber and small fiber. So what I mean by large fiber is you can have neuropathy in your feet that's related to your low back issue. Or you could have neuropathy in your feet because of diabetes or smoking or alcohol or a drug reaction, or you could have both. So a lot of times when I'm assessing a patient for neuropathy, I'm looking to make a very specific understanding of where their neuropathy is located, and that's going to help me determine so that I can talk to the patient about what we're going to do.
In general, just so folks kind of know, I was in my dad's podiatrist's office, and he showed us a big infographic that showed if your neuropathy is like over here on the outer side of your calf, that would be more L4, L5 from your back. And if it's over here, it's this and that. Can you go just run through some of that really quick? Because I find it so interesting. It's a big complaint that we get. They're like, we don't know whether it's neuropathy that's coming from my back or if it's something that's vascular.
Yeah, that's a great point. So typically what you're talking about is what we call dermatomes. So every nerve and every blood vessel, we look at them clinically in reference to dermatomes. That means what part of your foot, the inside, top, and outside of your foot, just like the inside, front, and side or back of your leg are different dermatomes. So when we're in the office, we're looking to differentiate. So the way to think about PN is that typically PN is what we call a stocking and glove disease. So you'll see it in the hands and feet and the smaller. Larger fiber disease, meaning low back, where you get sciatica, sort of the L4, L5, S1 type of compression. So your lower back nerve roots are damaged, and that will typically will present as a specific dermatome. So if someone comes in and they say, yeah, I had low back surgery and I said, well, did you have sciatica? Oh yeah, it was really bad on my right. Was it the outside, the whole leg? No, it was always the outside. So then I can tell based on what they're telling me that it was probably an L4, L5 without looking at their MRI, just basically understanding dermatome. But in a practice, when I'm doing a neurologic exam, I will typically start with a tuning fork because that's for large fiber. And I'm looking all around the foot and the ankle and the leg to see how the large fibers are doing. And then I'll go to what we call a sharp dull. I'll use a monofilament wire to look at the smaller nerves. And then we determine based on from that exam what we need to do next.
And we have a question about osteomyelitis. Would you mind just talking about the basics? What is osteomyelitis? And at what point do you need to have your toe actually removed with osteomyelitis?
That's a great question. So osteomyelitis, osteo refers to bone, and myelitis means there's something wrong with it. So we talk about osteomyelitis as a bone infection that either a bacteria or fungus or another organism has infected the bone. The good news is in 2024, almost never do you need to have something removed if we've been able to get that infection under control. So there are two types of osteolytis. There's what we call acute osteomyelitis, and then there's something called chronic. So acute is something that's new, that it's very active, and we need to get it under control. We can do that a couple of different ways. We can do it with antibiotics, usually IV, sometimes oral. And sometimes we need to remove some of that bone surgically so that we can allow the antibiotics either put on the bone in the way of pellets. We take antibiotics and we dissolve them into a material and we pack that into the infection. So we have a way of actually getting an antibiotic right to the problem. Sometimes we'll give antibiotics IV or oral at the same time. But the good news is, in this day and age, if you have an osteomyelitis and the osteomyelitis is stable, meaning it's been converted from acute to chronic, you don't necessarily need it to be removed. The rare exceptions to that in the toe are if you have an infection in the toe that has left the bone in such a way that the bone is either sticking out or it's in a position so the patient has a hammer toe and they're walking on the tip of the toe and that bone is causing a breakdown of the underlying of the skin. And oftentimes we can release a tendon to straighten the toe so that's not going to happen. Or if I have bone that's exposed, I'll look at the x-rays, talk to the patient about the treatment option. A lot of times we'll just remove a little piece of the bone so that I don't have to remove the toe.
That's good. And Tony had a question that came in earlier, and it was she had heard that iodine was just overused, for patients, and it just seems like the go-to over and over and over again. And it's interesting that you're also shaking your head because we have so many patients that will come to us with just a little bit of gangrene, and the doctor keeps saying, well, if you need to keep it dry, you need to iodine it, iodine it, iodine it. And what I was concerned about is that it does need some moisture, but the right moisture. But you don't want it to become wet. You don't want it to get infected. So where's the balance? And how does a patient know whether or not iodine is the right answer for them?
Yeah, iodine is a very old medicine. It does have some indications, and I'll qualify it. There's a couple of things you don't want to do if you have a wound. You never put straight iodine, and you never put peroxide on a wound because peroxide will kill the good tissue. The only exceptions when I might use iodine is if I have a patient who has some gangrene. There are two types of gangrene. There's what we call dry gangrene and there's wet gangrene. So wet is what you would expect. It's very moist. It's a wonderful environment for bacteria. So you have one problem, which is the necrosis of the tissue, which is causing the gangrene. The second problem with wet is that the bacteria loves to live where it's wet, dark, and moist, and that can spread to the other parts of the foot or to the bloodstream and make you very sick. So in a wet gangrene scenario, I don't use straight iodine. If I need iodine, which is very rare, I might dilute it. So 1 part iodine to 10 parts saline, sterile saline, and then I'll put that iodine on a dressing, and then I'll apply it. And what happens is it'll dry and it'll wick away. But I never use straight iodine, and I haven't had to use iodine in a very, very long time because we have lots of really good sophisticated dressing. So in a situation like for me, in a wet gangrene scenario, I would use what's called a silver alginate dressing. So it's a covered dressing by Medicare and most private insurances. And I would be putting that silver alginate dressing around that gangrene because it's going to absorb moisture and it's going to fight off infection. So it's a much better tool to use than iodine.
Fantastic. We have just a couple other questions we want to get to just really quick. We appreciate all of your time. I know Kim was asking, how do you deal with calluses on your feet at home?
Well, it depends. So if you're young and flexible, which I'm not, and you can get to the callus and you can see it, I would recommend, as long as you don't have underlying PAD or diabetes or PN or all the above, I would recommend 2 things. One is using a really good product, over-the-counter product like a CeraVe cream or a urea-based cream. The urea-based creams help remove the dead skin, and you would apply that twice a day. If you had a callus that needed to be brought down a little bit, and by a little bit, I mean sanded off a little bit, there's a wonderful tool called an Amope. It's a diamond impregnated roller. You can buy it at any of the big box stores, and it's battery powered, and you can buff that down as opposed to using a cheese grater or a callus shaver or, God forbid, a scalpel. You want to be very careful not to do that because if you take a razor blade, the razor blade, if you're trying to cut the callus, will have a tendency to go below and you then create a wound as opposed to shaving it off. If you do need a callus care for, going to a good podiatrist who will not only shave your callus, but talk to you about why the callus is there. A callus is usually a warning sign. It's saying that there's more pressure in an area than there should be. So just treating the callus palliatively by using a cream or shaving it down is really not enough.
Yeah.
I mean, it's a good start, but you really need to assess the patient. In my practice, I'll say to you, look, you have a callus here that shouldn't be here. And what's going to happen is the tissue between the callus and the bone is going to break down, and that's going to put you at risk for an ulcer, especially if you're a pad patient. So those patients will offload them.
So walking is the best medicine for peripheral artery disease. And one of the suggestions we always make before you start a walking program to always go to a podiatrist and find out, do you need orthotics inserts? How do we prevent these calluses? How do you make sure that the shoes that you're choosing are balancing your foot in the proper way so you don't get those calluses, those areas of significant pressure versus other areas?
Again, a great recommendation. I recommend walking to my patients all the time, and there are a number of things that you should do. If you're going to be walking, you should go to your podiatrist and get a look at your foot. Take your footwear with you. Take the shoes that you're going to wear, and make sure that the podiatrist looks at the shoes, inspects inside and outside. And then I always take the insert out of the shoe. I line it up to the foot to make sure that it's the right size. And invariably, patients are wearing shoes that are the wrong size, and that leads to irritation around the toes and causes blisters and complications. So the size of the shoe really matters, the condition of the shoe. And then the type of shoe. So we know that patients who have a shoe that's too thick or too high in reference to heel, that tends to promote falling. So there are some good walking shoes. You walk in a walking shoe. You don't walk barefoot. You don't walk without socks. You don't necessarily need a running shoe. You don't walk in your $5 Old Navy flip-flops. You have the appropriate shoe that's fit perfectly, that your feet have been checked, and you have the appropriate socks. The socks matter. You can get a good what we call a bilayer sock. There's a brand called Thorlo, Thorlo, that makes a bilayer sock that the two layers of the sock will rub on each other as opposed to rubbing skin against shoe. But again, bring your shoes, see your podiatrist, get an exam. Not everybody needs orthotics. Sometimes it can be an over-the-counter device. I have a wonderful store in Delray Beach called Fleet Feet. It's a brand of store. I literally have their thing. I literally write their name, my name, and I said, listen, do not pass go. Do not collect $200. You go directly to the Fleet Feet store, and I want you to get fitted for the appropriate shoes. I want you to get the soft inserts they have, and then I want you to come back in 2 weeks and see me because I want to make sure that it's okay.
Okay, we have one more question here. And Marie, do you want to ask the question yourself? Do you want to go ahead and unmute and ask the question?
Will you do it?
Hi, Marie.
Okay. People keep telling me that I shouldn't be cutting my own toenails because my toenails are getting brittle because my leg keeps blocking, but I've never had an issue. Why does everybody seem to think it's like so dangerous for me to do it?
Marie, that's a great question. So, without getting into your medical history, I would assume if your nails are brittle, it would be best to have somebody, either a good podiatrist or go to a spa or nail salon that has licensed medical techs, not ones that came off of some sort of slavery thing and work at a spa salon. You need to go to somebody who's well trained to trim your nails. The reason why is that as we get older, and I'm 60, and I'm not as flexible as I used to be, being able to see, reach, and cut appropriately is important. And sometimes you can miss and end up with an injury. So that is super important to make sure you're receiving the appropriate care and a professional that can do that for you. It's not a big deal because think of it this way, Marie. You're going to be going in, if you have Medicare, it's going to be every 2 months or so that's a covered service. And if you're going in, the provider or podiatrist that you should be seeing should be assessing your blood flow, assessing your neuropathy, looking at your skin, assessing the joints, looking at your shoes. It should be more than going in and just getting your nails cut. It should really be a whole 360-degree assessment of your feet. And if that's not what you're getting when you go, see somebody who'll do that.
And Marie, you had one more question.
Okay. I've had numerous procedures done, and it seems like after, I'd say probably the last 15 of them, 15, 20 of them, the bottom of my left foot after they restored the blood flow, the skin is like really, really thick. And I can just sit there and peel it back. And I have to do the whole foot. And then it's like all brand new pink, pretty skin underneath. Why is it so thick afterwards?
Well, okay. So the first thing, the explanation for why is your skin is the largest organ in your body, and you have the changes in your skin because of what happened to the skin as a result of the underlying blood flow. So what you want to do is you ask the first question, which is about nails. The second question is about the skin. You definitely need to have a really good podiatrist looking after you on a regular basis because you've had a number of procedures done, which puts you at risk. And you do have two things that need to be treated. If you are my patient, I would be seeing you on a regular basis. We'd be taking care of your skin, taking care of your nails, and I would be prescribing some prescription medications that actually is going to reduce the thickness of that skin. There are a number of things that I can prescribe for you that would reduce that.
Fantastic. Thank you so much, Dr. Bromley. I really appreciate all your time. There's so many amazing, there are probably a lot more questions to get to, but I'm wondering if you would come back again and let's do it virtually from your office and let's do another What's Up Doc session with you.
Yeah,
If you don't mind.
I love this and I love what you're doing, and I'm
Thank you.
so grateful for the opportunity. And I'd talk to you anytime you want to talk to me.
That's a deal, right? I think we should get them on and do something regular, maybe once a month, have a
Anytime,
What's Up Doc.
anytime. I love this.
Fantastic. And I appreciate every single one of you for showing up and for your courage to ask questions. And just I love that you're learning. So I see Kim here. She has a podiatrist appointment this afternoon. So this has really been helpful. Thank you again, Dr. Bromley, and thank you everyone for being here. And if you have more questions for him, go ahead. You can put it in the chat and I'll try and get them to him and we'll get him on again very